So next is ERCP perforation, and it's video 16. You are called to see a 50-year-old female patient who is complaining of severe upper abdominal pain. She underwent an ERCP and sphincterotomy 6 hours earlier for cholecystectomy. The procedure was technically difficult due to a periampullary duodenal diverticulum. Examination: she is tachycardic, paraxial, and has mild upper abdominal procedure. White cell is 14 and mile is 150. What is the likely diagnosis? She is likely to have bowel perforation because post-ERC pancreatitis is differential but is unlikely given the minimal hyperamylesemia. Perforation during ERC is most likely if there is a periampullary diverticulum and if sphincterotomy is performed. This is a rare complication occurring 1 in 2000 procedure, but with a significant mortality of 5-10%. What are the risk factors for ERC perforation? Periampullary diverticulum, sphincterotomy, particularly if the patient has previous sphincterotomy, and dilated CBD, and sphincter forti dysfunction, and Billroth 2 gastrectomy. How was the ERC perforation classified? There is a classification system called Stepfer classification. So Stepfer classification, 1 is hole in the lateral middle wall of the duodenum, 2 periampullary perforation, 3 distal ductal perforation, and 4 retroperitoneal air only. How would you manage these patients? In the absence of the peritonism and systemic compromise, this is unlikely to be a major abdominal perforation. Looks like step for grade 1 and is therefore likely to be suitable for conservative treatment in the first instance. Sustain the patient, nil by mouth, IV fluid, antibiotics, and including another cover. Place nasogastric tube to decompress. And if I would catheterize the patient for early urine output, request CT scan abdomen with IV contrast to confirm the diagnosis, address the side and nature of the perforation. If perforation was shown to be periampullary or ductal, I would consider stenting of the bile duct. I would regularly review the patient. Low threshold of central venous GPN. Conservative management successful in 90% of the cases. Subsequent iteration sepsis, I would bring the patient in theatre. What are the indications for surgical intervention? Obviously, recognized major duodenal injury at time of initial procedure that cannot be managed endoscopically. Number 1. Number 2, peritonitis. Number 3, significant leak of oral contrast on the CT scan. Number 4, sepsis due to severe, despite conservative management, failed fluid collection on the imaging, and unresolved problem for retained hardware. How would the management differ if the perforation was Stepfer grade 1? So 75% of the major duodenal injuries are recognized at the time of initial ERCP. If recognized through the scope clips, can be applied to attempt to close the defect if successful. If identified after the procedure, then these clips are not feasible. Patient become on antibiotics and taken to theatre immediately. At laparotomy, the management depends on the time since injury and the degree of the contamination. If it's less than 12 hours, duodenal defect can be overseen through thorough washout and the drains placed. If more than 12 hours, extensive contamination, considered duodenal diversion procedure. After the repair of the defect, soluble pyloric exfoliant, aggressive jejunostomy, and tube duodenostomy. Thank you. It didn't mention the complication of the ERCP. The complication of ERCP are hemorrhage, perforation, pancreatitis.